Welcome to episode 199 of the Sisters in Loss podcast. April is Sisters in Loss Infertility Awareness Month. All month long, we have been highlighting infertility stories and journeys. This month, we've experienced Black Maternal Health Week, which was April 11th through 17th, as well as Infertility Awareness Week, which was April 18th through the 24th. This week, we are talking all about reproductive health. Did you know that some midwives specialize in high-risk births and pregnancy after loss or infertility? Today's guest is Takia Ballard, who is a certified nurse midwife and founder of Sakina Health, who partners with birthing families to inspire them to become savvy birthers. After spending nearly 2 decades as a midwife with nearly 1,000 births in the hospital, birth center, and home, Takia knows what it truly means to offer a unique type of healthcare that is unbiased and respectful in every way. In this episode, we deep dive into the state of Black maternal health. We discuss the differences between midwifery and doulas. We discuss her podcast, The Savvy Black Birther, and really how can we create the right birth team for ourselves. This episode is for you to listen to if you want to learn how to create the right birth team for you, the differences between midwifery or midwives and doulas, and how you can take control of your reproductive health. Here is Takia Ballard.
All right. Welcome to the podcast.
Thank you. Thank you so much.
Yes.
I'm excited.
I'm so excited to have you. I would love for you to just introduce yourself to my audience. Share a little bit about yourself and what you do.
Absolutely. My name is Sakina Ballard. I'm a licensed certified nurse midwife, and I've been a midwife for over 17 years now. And basically what I do is, or what I have done in my past, is a graduate of Syracuse University with my nursing degree and license, and then a graduate from New York University with my master's in midwifery. And I've worked in home, hospital, birth center, and really just, delivering lots of babies over that time frame and helping families welcome babies into the world. I've experienced in the hospital setting and high-risk midwifery as well, or high-risk care, delivering babies that are twins, breeches, women who have had infertility issues and pregnancy loss as well. I've also worked with people who have had HIV or AIDS and are delivering with midwifery care. Most recently, I have retired and I am now a host of the new podcast, The Savvy Black Birther. And I am also a midwife working with families virtually and future midwives and future nurses in the community. So working with them with mentorship and helping them sort of navigate their path towards their career. So I'm excited to be a part of the Sisters in Loss podcast and to speak to you guys today. So thank you so much for having me, Erica.
Absolutely. And we also did a podcast, so definitely go back and listen to
the
podcast where I was able to share a little bit of my story, my journey, and just really kind of what I do and around, Black women with pregnancy, loss, and infertility. So definitely go check out her podcast, and I'll make sure I link it in the show notes as well as our description box. But I would love to talk, obviously, going into April. April is what I consider Sisters in Loss Fertility Awareness Month, really for us to really talk about fertility. But really, second week of April is Black Maternal Health Week. And then the last week of April is what they consider National Infertility Awareness Week. So it's kind of coupled all up in one month where we're really talking about fertility in the Black community as a whole, but also what are we doing and championing around Black maternal health in the spaces that we occupy. So I really would love for you to share, especially in light of COVID-19, because we're still in this pandemic. We're still dealing with a lot of the disparities amongst Black and Brown communities with access to care, even in COVID. What is the state of Black maternal health right now, in your opinion?
Yes. The state of Black maternal health is one that has a really big question mark. There's a lot of things that are still going on, a lot of things that we're seeing in the media, being portrayed in the media. And while the statistic is pretty much holding steady at the 3 to 4, 3.5 times more likely that a Black woman would suffer morbidity and mortality, having issues of pregnancy loss, all of those things are still holding true for Black women when it comes down to pregnancy and then the thereafter and the postpartum. And so we're seeing that statistic really the 3 to 4 times more likely that we would lose our lives related to birth or thereafter. So that is really one of the biggest things. But there's other things like infant loss and things like that and infertility that have not really reached the clout of notice by our community, but the statistics are still there. And the statistics, unfortunately, have not been something that are new. These are statistics that have been around for a long time, but we've been paying more attention to it in light of what's been going on socially for our community and socially for the world, America. And that is when people like Beyonce and high profile people have been affected by the statistics, then we realized it. Now that more media outlets are, talking of the story of Black maternity and Black mortality for mothers, we're seeing it more and more in our social media feeds. We're seeing it more and more on news outlets and things of that nature. And we're seeing more people sort of answer the call or answer to the alarm of what's going on. We see more stories being evident. We're seeing more people talking about their experiences and sharing on a more public format. And so when we look at the state of maternal mortality, specifically for the Black community, not much has changed in terms of statistics. But what has changed is that there is talk. There is a notice, there's an alarm being set. People are being made aware of the situation. However, in my opinion, although they're being made aware of the situation of what's going on in healthcare when it comes down to mortality and the infant and then mortality and the mother, the issue is that now we're seeing crippling fear happening within the community because the alarm has been set, but there has not, the response is sort of a knee-jerk reaction. And it's the response really is what's happening there is that people are now afraid to even get pregnant. They're afraid to move into that dream or that aspiration to have a family. They're not sure who to go to. They're realizing that there are not a lot of Black practitioners out there. They're realizing that there's not a lot of midwives. There's not a lot of doctors that are Black and they want to be taken care of by someone who's Black. But the reality is that we're hard to find. And so now that is also setting up a sort of a roadblock for people because they undeniably want to be taken care of by somebody who looks like them. And so that is one of the struggles that we're seeing is that there's a knee-jerk reaction of fear of not wanting to go in the hospital, wanting to be outside of the hospital at all costs. But the reaction is not being met with the education. And so the education needs to be there to understand what does it take to deliver outside of the hospital? What kinds of commitments do I have to have? What kind of financial availabilities do I need to have? What kind of resources do I need? The other thing that we need to look at too when you're deciding to deliver outside of the hospital is how do I move in the way that healthcare will support it, my insurance, all those different pieces. Who should be a part of my team? And then we have to understand that delivering outside of the hospital does not equate to delivering inside of the hospital. It's two different worlds, two different processes. And so these are the things that are coming up now as people are looking at delivering outside of the hospital and having more choice. The wonderful thing about what's been happening is that people are waking up. And to me, that is the biggest thing that I see as the benefit to knowing this information is that people are waking up and they're realizing that they have to do something different as a healthcare consumer. They have to be a little bit more tenacious and more involved in their healthcare. Whereas in the past, we would just literally go and consume the healthcare and be told what to do with our own bodies. People are realizing now that they have choices that they have to make and that they have to be at the table, the front of the table or the front of the line when it comes down to making decisions for themselves. So it's a lot of things going on when we're looking at it. But nonetheless, I think we're talking about things and that is very important.
It is. And I think that I love what you said about how to really create a team around us, whether they look like us or not, but to know that we have the option to do so. And having the options gives us room to really make informed decisions about really everything that pertains to our bodies. So what I also want to talk about and dig a little deeper is the differences between birthing in a hospital versus birthing at home or traditional birth center. And really what that comes down to is the care that you receive, whether it's a care, having a care of a traditional OBGYN, or are you getting care under a certified professional midwife or a certified nursing midwife? So let's start there. Let's talk about the differences in midwifery. And then if you can go into the differences on roles and responsibilities that a midwife have versus a doula.
Absolutely. Unfortunately, midwifery has been divided. And so midwifery is a very old profession. It's probably the first profession ever recorded where we see a woman helping another woman. It's recorded in biblical times. And so midwifery is not anything new under the sun. The reality is, as we have become industrialized as a nation and as we've progressed as a community of human beings living on this earth, we have institutionalized midwifery. We have made the care of women an institutionalized process, one that can be capitalized on, one that has systems and procedures and protocols. And while in some cases that can be a positive thing that adds structure to how we consume care and how we receive care, and it adds accountability and all of those things that we need, it has in many ways stolen the sanctity and the validity and the respect that birth deserves. And that's birth in any way that we look at it, whether it happens in the first trimester, second trimester, third trimester, governance of over our own reproductive rights and our abilities to take care of ourselves and to know what's best for ourselves as people who have reproductive organs. I mean, it's a whole, thing. But the reality is when we look at midwifery, we see that midwifery has changed over centuries, over years. And now we've come to a more industrialized field to midwifery where you have to be licensed and certified and designated by your county, designated by your local municipality to work, your government to work in that facility or to work in the home or to work in a birth center. And so there has to be an education that goes behind it, whether you receive a certification or you receive a master's or a bachelor's. Nonetheless, there are several types of ways that you can become a midwife or several ways that you can be certified as a midwife. Nonetheless, we do a lot of the same things. Unfortunately, that division has caused that designation of the types of midwifery has caused a division within our practice of midwifery. And so we see midwives being isolated in their respected areas of practice. So you see midwives in the hospital setting, you see midwives in the home setting, you see midwives in the birth center setting, and oftentimes they don't collaborate and they don't mix. And that's because of rules and regulations, policies and procedures and governances of, state that we're living in. And mind you, those governances are not the same state to state either.
Exactly. I was about to ask you, they are very different from state to state on how process and procedures are done. Even just me thinking about, someone may have, something going on in their birth setting, whether it's in the birth center or at home, and the transfer policies change from state to state on when they transfer to the hospital. So it's something that is very detailed that you have to really know and understand when you are considering, taking on, home birth or a birth center birth in your particular state, especially.
Absolutely. So when we look at the different types of midwives, you have your certified professional midwife, which is a midwife that learns traditionally from an apprentice style way of learning, which is really how midwifery started. You learn from the midwife before you, and you learned more of a hands-on approach and how they practiced. And so it takes on more of that approach. It does have didactic or in classroom teaching and instruction, but they really focus on the apprentice style of learning the craft and the art and the science of midwifery. And they come out, they're certified, and they're licensed to practice. Now, again, certain states license CPMs. And so CPMs are more restricted than any other practice because that is, again, likened to the idea that it's less medical and less knowledgeable. And I put quotes there because the reality is that is very, very false. The idea that midwives who are CPMs are just as knowledgeable, if not more knowledgeable, in my opinion, than midwives who were trained in the more formal education of the nurse midwife. Now, again, if you look at the history of midwifery, you'll see midwifery began as just midwifery, and then it became a requirement to be a nurse and then become a midwife. And those are where the changes began for the profession of midwifery. We have also certified nurse midwives. That just simply means that they are registered nurses before, were educated formally as a registered nurse, and then began training as a midwife. They likely have bachelor's and master's, so a higher level of degree. And so these individuals are now practicing in hospitals, birth centers, and homes. Whereas the CPM is actually refrained from practicing in the hospital setting in most cases, depending on the state legislature. And then there's one more group that is actually even smaller than the CPM group, which is a certified midwife. And that individual does not have any prior clinical experience, that meaning a nurse, but they are certified as a midwife under the same jurisdiction as a certified nurse midwife. They just don't have the nursing perspective or the nursing education prior to. So those are your three types of midwife. And the CPM sort of direct entry person, that person is also coming from usually a non-clinical background. Now, again, you can become a registered nurse and also become a CPM, but there's so many different ways that you can enter midwifery. Nonetheless, no matter who you are, you have to be licensed by the state and certified to practice. And so when you're looking for a midwife, you want to know that they're licensed and certified to practice in your area. You also want to kind of find out, what their background is, what experiences have they had, where have they practiced and things like that. In terms of the difference between a midwife and a doula, there's very big differences. And most people don't understand the differences because we sort of do the same work in the sense that we are advocates for birth. We are activists for the reproductive rights of individuals. And so we have the same language and we speak and move in a lot of the same ways. Where the difference is the line is drawn is that we as midwives have a clinical aspect to our practice. We are responsible for pregnancies. We deliver pregnancies and help women or help birthing people birth their babies. And then we take care of the families after the babies have been born. Midwives can provide gynecological care and they can provide support when it comes down to infertility or conception or contraception for that matter. So midwives can do the clinical hands-on approach to taking care of a person. We write prescriptions, we do physical examinations, all of those things. And then the doula on the other end of things can educate and facilitate and help families with breastfeeding and whatever their specialty is. They could be a bereavement doula. They could be, a doula that helps with abortions. They could have extra specialties that will sort of color the way that they care for you or how and what they are able to offer in services. But where the line is drawn is that they do not offer clinical services. They cannot prescribe. They cannot be responsible for the pregnancy. They can't order labs, tests, sonograms. They can advocate, support, educate you, and walk alongside of you. But when it comes down to the clinical piece, that's where their abilities cease.
Absolutely. And even in my, experience as a doula, working with midwives who are of a different hue, it's a difference. And I'll say this as frank as I can. They will let you know that there is a line drawn and that they're not going to do certain things when it comes to caring for the patient emotionally and physically. And they're just going to say that's a doula's job. Compared to working with the doula, a midwife, in my personal experience, that's Black, that's a woman of color, they're a little bit more empathetic to understanding, how a Black birther's experience is going to be. And they're more sensitive and empathetic and compassionate about how they can take them through that transition phase along with the help of a doula. So I've always enjoyed working with midwives who understand that as a Black birther, there's a little bit more you will need to get you to the other side of birth. Mm-hmm. And unfortunately, what I've seen happen in a lot of our communities where birthing options are limited, a lot of people end up going and birthing at birth centers that are owned by majority white people, and they don't get that experience that they want. So let's talk about that. Really, how can we as Black birthers, as many of the women who listen to this podcast had some challenges, right? We've navigated through loss, through miscarriage, through infertility journeys, whether we've had fibroids or endometriosis or PCOS, and we want to have this empowering birth experience, whether it's in the hospital or outside the hospital. How can we navigate that as Black birthers?
Absolutely. Part of navigating the healthcare system is knowing the healthcare system. You have to be able to, number one, know the healthcare system, and number two, know yourselves and your needs. So it's going to take a shift in your mindset, a shift from what we are used to. And that is, we are used to going into the healthcare system, taking that shiny white card with a few letters on it, from insurance company ABC, and we take that and we go to the doctor's office and we expect that they're going to tell us what we need for ourselves and that particular card is going to pay for that service, and we walk away and that's it. And then, sometimes we ask questions and most times we don't. We walk away with a prescription. We walk away with, a change in the plan, and we really don't understand what's going on for us in terms of our health. So first and foremost, we have to learn what the healthcare system looks like typically. And then we also have to know what our needs are physically, emotionally, spiritually. So first, when we look at the healthcare system and what it looks like, we have to understand that there are key players within the healthcare system. First is their health insurance. How does that work? What is my actual benefit? Do I have health insurance? If I don't, how can I get healthcare insurance? What does that look like in terms of out-of-pocket costs? Most people don't understand that health insurance companies were never intended to pay 100% of our care. Never. From the inception of healthcare insurance, it was never intended to pay 100% for our care. It was intended to be a partner with us as we pay for our health insurance, as we pay for our actually healthcare, right? So when we look at benefits, we have to make sure that when we're applying for jobs or where we're having a change in our employment or we are changing our benefits, that we're reading those fine print, that we're understanding the terms. We're just not picking an insurance company based on how much is coming out our check every 2 weeks. We're picking it based on what our needs are. So if we know that we access the healthcare system because we have diabetes and we need to see our endocrinologist on a regular basis, then that means that we need some hella good health insurance so that we can make sure that we are getting our appointments done, and we're not limited on how much we can be seen. We're also not limited because it costs a whole heck of a lot of money just to go for one appointment. So we have to understand terms like deductibles and co-insurance and co-pays and how that really applies to our needs and what our health concerns are. The other thing that we have to do is change our mindset from the idea that the person that's sitting on the other side of the table with the white coat and all the letters behind their name knows more than you about you. That is the biggest thing, because at the end of the day, you've been living with yourself all of your life and you know you better than anybody in this entire world. So get to knowing, get to documenting, get to representing yourself better. Be your own lawyer in that courtroom. Be your own advocate in that healthcare exchange between you and that healthcare provider. I don't care who they are. They can be a nurse, a midwife, a doula, whoever they are. Make sure that you are in that captain seat and that you are in charge and they know it. Also let them know that every dime that's coming out, whether it's coming directly from your pocket or whether it's coming indirectly from your pocket by way of your insurance company, is you paying for a service and you're expecting a specific type of care and a level of care. And demand it. And don't be afraid to demand it. I have had people approach me and be scared to say what they need. Come intimidating in an intimidating way. Well, I'm not sure. What do you mean you're not sure? You have to be in all circumstances, sure about your needs first, be able to identify your problems and what's going on with you. And then the healthcare provider can walk alongside you and offer you the information because they're savvy in that. But by no means do they know more about who you are than you do. So those are really key things to understanding and being a better navigator and being a better healthcare consumer is looking at it from a perspective of consumerism. We do not dare plan a wedding without testing out the cake and making sure we check in this and check in that. We don't drop a deposit until we're sure that we like it. We will window shop until we are sure we want something. Why don't we do the same when it comes down to healthcare? And we've been conditioned to be healthcare consumers, right? To not ask questions, to not buck the system, to follow the protocol, to say, yes, doctor, yes, nurse, yes, midwife, whatever you say. And it could be harming us. And we wouldn't even be any wiser to it. So it's really important to make sure we elevate our mindset. We become self-determinant. We become self-advocates, and we walk in that. And we make sure that people understand that we are very aware of what our needs are, and we are able to articulate and communicate that to the healthcare professional.
Absolutely. So what happens if we do this? We go in, we change our mindset, and the doctor we're seeing before, they aren't giving us what we need. We're not getting that same quality of care because we're advocating for ourselves. What do we do in those situations?
The same thing we would do if we were in a restaurant and the food was nasty as hell. The same thing we would do if we put on a pair of shoes and they don't fit. Take those suckers back and get your money. Quit the person, say, peace out, thank you very much, but I don't need your services. I'm going elsewhere. The same thing we do when we're dissatisfied. When we're dissatisfied as consumers of any other service or product, we will walk away from that service or product and say, I want a refund, or I'm done with your services with no problem. But when it comes down to healthcare, we don't know how to do that. And so that is, again, a change in the mindset that if you're not satisfied, make your dissatisfaction known. Tell the person that you're working with, I'm not happy right now. And if you can work it out with that person, great. But if you can't work it out with that person, then you need to walk away from that person and find another provider. The biggest thing to being satisfied with your healthcare provider is doing your due diligence of vetting that provider and understanding who that provider is before you even hire them. Consulting with them, making sure that they are who they say they are, that they are who they say they are. And you see it as evidenced and manifested in reviews. You see it as evidenced and manifested in the statistics that are online about them. You see it evidenced in your experience with them because you're sitting face to face with them and you're asking them hard questions. You are seeing it evident when you're sitting in their office and you're gone for your first appointment and they're not blowing you off because you have questions. That is how we address when a person is not meeting our needs. We first of all make sure that we are finding good providers in the beginning so that we don't have to go through that song and dance of, figuring out who we like and who we don't like or being dissatisfied. And then we definitely, if we have approached or we've seen that we don't like a particular provider, that we're definitely making it known to them, letting them know that we're dissatisfied and either deciding at that point to move on or not.
Absolutely. So lastly, I want to talk to you about this vaccine. We kind of started to talk about this before I press record, but obviously, I haven't really shared and talked about it on the podcast thus far. But I want to just talk about, obviously, there's been a lot of stigma around this COVID vaccine, particularly here in the U.S. I have listeners all over the world, but particularly here in the U.S., around Black people's hesitation to get this vaccine. Obviously, everyone, it's a personal choice for everyone, but I really want to pertain it to Black birthers, particularly those of us who have already experienced trauma in birth, whether it's through loss or infertility, and us trying to conceive. For those of us who are listening who may already be pregnant and are getting conflicting information around should they get this vaccine or should they not get this vaccine as someone trying to conceive, as someone who is currently pregnant. So I would love for you to share just your experiences with some of the folks that you talk to and what you've learned just by, doing your own personal research on the CDC website and all the other research that's out there.
Right. Well, of course, it just like anything, when we have something that we are not really familiar with, like COVID and the COVID-19 pandemic, it hit this world and more specifically our country like a ton of bricks. And our reactions to it were knee-jerk reactions. Of course, we were isolating ourselves and we were, doing all of the things that we thought as a nation and as healthcare providers who govern the healthcare space, trying to prevent, transmission of the virus to other people and trying to safeguard ourselves and all of the things that we do. Of course, a vaccination, is something that it was needed to try to remedy the many deaths and try to prevent, subsequent deaths. The reality is that, unfortunately, because of the gravity of this pandemic, we have not really had an opportunity to really look at the use of this vaccine and its efficacy. We've seen that the FDA has not approved it quite yet. We see that the CDC is urging us to take it. We see that there are manufacturers that are urging us to take it. We see government officials and people of high political standing and social standings are encouraging us to take it. And it makes sense that that encouragement would be there because, again, of the gravity and the loss that we've all experienced because of this, virus. But the reality is that when we look at the statistics and when we look at the information, it's just not strong enough to support a full push. I think that the decision is really going to have to be on the personal level of every individual who has the ability to choose. You're going to have to go out and you're going to have to do your own research. You're going to have to decide whether you're okay with what's being disseminated right now. You're going to have to figure out if you're okay with what the statistics are currently, because the evidence is gathering as we are providing the vaccination to individuals. The evidence is gathering as we're seeing the outcomes of the virus. The evidence is gathering. And so we just can't say that we have concrete evidence right now that's been studied and tried and true, and that's evidence-based to provide you that assurity that first, the vaccine is even going to work. And number two, it's safe to even take, depending on whether you're a pregnant person who's in the first trimester, second trimester, third trimester, if you're a parent who's looking at trying to vaccinate an infant or your older children. It's really just not a lot of information out there. So I would say make your decision based on doing your research from valuable and reputable sites. I would also say make your decision based on your needs of your family, whether you have any comorbidities, whether you have any sicknesses in your family, whether your children or you are at higher risk because you have to work or you go to school or whatever the case is. But I have a pause as a healthcare professional, as a midwife who has talked about vaccines before, who has given vaccines before to people who desired them. Where I have the concern is that we are telling individuals who are pregnant in their first trimester that it's okay to take it. And to me, that gives me pause because in any other situation, when I'm telling a person to take a Tdap vaccination for whooping cough, or I'm telling a person that it's okay to do these things, we're telling them that it's okay to do it in their second trimester and beyond. And that is because in the first trimester, we see that there's a lot of cellular division, a lot of forming of the organs and the creation of that baby, making sure that all of those things are done. And so we don't want to have any what we call teratogenic effects or effects of the development of that baby's body in that first trimester. Is such a critical time. So we want to avoid exposures that would risk malformations at any cost. And that also includes, in my opinion, vaccinations. And so I would very much caution anyone who's in their first trimester, especially an individual who is in their first trimester and they've experienced loss before, that person also really at all costs, if this pregnancy is that pregnancy that you're just dreaming and hoping for and wanting to manifest as a live delivery of your baby, it's really important to safeguard yourself, protect yourself, make sure that you are looking at how to decrease your exposure to others, but you're also really heavily considering that this vaccination may not be the right choice in your first trimester. Again, every choice is an individual choice, and every choice should be guided in your own beliefs and your own values and your own desires and needs. But do know that in that first trimester of pregnancy, there is a lot of things going on at the intricate cellular level that are important to be not disrupted or uninterrupted when we're trying to have that baby grow.
Absolutely. Well, thank you so much for being on the podcast. Where can our listeners connect with you after this episode?
Absolutely. Thank you so much for having me. They can connect with me on Instagram. I don't do too many social media outlets. I just started a clubhouse, and that is Takia B. And then on Instagram, I'm Sakina_health. That's SAKINA_health. And I also, you can find me on the Savvy Black Birther podcast. And there's also an Instagram page for that too, at Savvy Black Birther.
Awesome. Thank you so much, Takia, for being on the podcast. It is always a pleasure to talk to you.
Thank you. Thank you. Thank you.
Thank you so much for listening to today's episode. There are so many ways to connect with the Sisters in Loss community. Join our monthly support group, our Sisters in Loss Healing Collective at sistersinlosshealing.com. Join our free Facebook group at sistersinloss.com/community, or text sisters to 797979 to download your free Journal to Healing ebook. That is sisters to 797979 to download your free Journal to Healing ebook. Follow us on Instagram and Facebook at Sisters in Loss, and subscribe to our YouTube channel. Yeah, girl, we on YouTube at Sisters in Loss TV. We love you for listening. Keep the faith. Until next time, this is Erica, and I'll talk to you soon.
It's Chevy truck season, and there's no better time to do what you do best. No better time to get the job done in a Chevy Silverado with best-in-class standard torque and a TurboMax engine with a 5-year, 100,000-mile limited powertrain warranty that outlasts both Ford and Ram. So kick off whatever your thing is season right, because it all starts with a Chevy truck. Click to learn more.
See your Northwest Chevy dealer.
Based on latest competitive data, excludes other GM vehicles, whichever comes first. See dealer for limited warranty details based on Ford and Ram 5-year, 60,000-mile warranty on gasoline engines.